Guidelines, which one to use? Since levodopa is the one that is actually the gold standard, we want to say that why don't give them the best treatment? But then again, because levodopa has a higher chance of being prone, depends on how we actually give the levodopa, of motor complications. So we may want to say that why not we choose dopamine agonists, all right? Dopamine agonists, on the other hand, although it can help to prevent or delay the complications of motor fluctuations, is not as a strong drug as levodopa if you compare their efficacy. The consensus right now is if a person is young, we know that they will tend to develop motor complications much more likely than older people. They will tend to live with the disease for a longer duration of a period. And therefore, we tend to start the young patients on a dopamine agonist first. We slowly work from one type of dopamine agonist to the other types of dopamine agonist, increasing the dose. And if it really cannot work, that's when we actually change or even add on to levodopa. But for the elderly, let's say in the geriatric age group, sometimes we will say that give them the best because the disease duration is much shorter and the chance of them getting motor complications, well, maybe if they develop the disease in their 80s, right, they may develop the motor complications, maybe they're 100 or 100 plus. So why do we want to actually keep them having a less efficacious drug? So you tend to actually give them the best drugs or go straight to levodopa. And we can actually maybe reduce the dose of levodopa by adding on the dopamine agonist and so forth. Therefore, our guidelines suggest that in younger PD patients, therapy should commence first with a dopamine agonist rather than with a levodopa. Now, Dr. Chris have touched on briefly on the different types of motor fluctuations and dyskinesia, and this is something that if a person has all these complications, sometimes it's difficult to tell from one to another. They may say that they have wearing off when the medication is not working, or they can have suddenly off. That means even though they took the medicine, suddenly they find that the medicine is not working at all. They may delay on. For example, they usually take about half an hour, 20 minutes to feel the effects of medicine. Sometimes they take the medicine only 1 hour later than they feel the effects. Or the dose failure, that means it doesn't work at all for that dose. You can have all the different types of dyskinesia occurring at the peak of the dose or maybe at the end of the dose. Now, these are very complicated, and I think it's better to refer such patients to the specialist to actually monitor the conditions and then sort of titrate the medication. But in the early stages, Parkinson's can be managed by any doctors, or be it a family physician, specialist, geriatrician, so forth. In the early stages, most of us can manage. But once it actually develops the motor complications, I think that's where we actually need to have some shared management to sort of refer to a specialist to sort of re-diagnose the conditions, stabilize the condition, and then suggest some form of a treatment regime. When it comes to motor fluctuations, therefore, we have talked about briefly on dopamine agonists. Therefore, we try to start young, in the early stages, dopamine agonists, hoping that we can actually prevent or delay the onset of motor fluctuations. But if motor fluctuations or dyskinesia have already occurred, then we may have considered two different types of medication right now, the amantadine as well as the COMT inhibitors. Amantadine is actually an antiviral agent but was accidentally discovered to have some mild anti-Parkinsonian effects. It was discovered at around the same time as levodopa, and therefore it did not really take off as a treatment, because its efficacy as anti-Parkinson effects is actually very mild. It's only recently they find that amantadine, other than its anti-Parkinsonian effects, may also help to modulate the severity of the dyskinesia in patients with motor fluctuations. And because of its anti-dyskinetic properties, it has been suggested that it could be used in patients with some form of motor fluctuations as an add-on therapy to levodopa. But the anti-dyskinetic effects is usually very short-lasting, maybe efficacies for about 8 months to a year, after which you no longer see actually much benefit from it. Side effects, it can cause hallucinations, cognitive impairment, and so forth. So evidence have shown that amantadine can be used as a symptomatic treatment or as a adjunct treatment, but it can also be considered as a therapy to reduce the dyskinesia in patients with motor fluctuations. COMT or COM10 inhibitors, entacapone, blocks the enzyme that converts levodopa to dopamine. Therefore, it actually causes more levodopa available in the body system and therefore go to the brain. Therefore, COM10 on its own has no effect. COMT inhibitors have to be taken together with the levodopa at the same time. So if a person, if you see, is actually on a COM10 and levodopa in your clinic, and then they say that, doctor, no, I don't seem to, you give me the new medication, doesn't seem to work. So always ask them, are they taking the medications together? All right, they must take the medication together for this to be effective. On its own, it's not effective at all. Side effects, because it increases the bioavailability of levodopa, therefore it actually increases the amount of dopamine eventually in the body. So the side effects you can think in terms of the side effects of dopamine, dyskinesia, nausea and vomiting and so forth. Therefore, if a person you start on COMT develops dyskinesia sort of worsen, you may actually suggest that they can actually reduce the individual dose of the Madopa, for example, from 1 tablet to about 3/4 tablet, all right, and then take each of them with COM10. The other point to note about COM10 is it can cause discoloration of the urine. So COM10 is actually orange in color. Therefore, once they take it, they may find that the urine is a bit orangey red in color, and then they thought they have hematuria. So warn the patient when they're starting on COM10 that the urine may change color. It's great evidence that entacapone is efficacious and is useful in patients with motor fluctuations, especially those with wearing off symptoms. What about there's some literature that shows that what about maintaining dopamine throughout the body? Because there's some literature that shows that the motor fluctuations in dyskinesia occurs is because the way we actually give the levodopa. In the past, we give levodopa like twice a day, 3 times a day in a very pulsatile fashion. And is this pulsatility that actually is non-physiologic, and it sort of resets or remodulates the receptors such that the receptors become very super hypersensitive to the dopamine, and therefore it can cause all this dyskinesia and motor fluctuations. Dopamine agonist, on the other hand, produces a very smooth 24 hours response in the body, although it's still being given as twice a day or 3 times a day or even 4 times a day regime, but the plasma half-life is actually much longer, and perhaps that's the reason why they are not actually causing all this motor fluctuation and dyskinesia. And therefore there has been postulated that some authors suggest of giving continuous dopamine. So you give them maybe frequent dosing or maybe infusion and so forth, rather than pulsatility. And because of this reason, a lot of people have been advocating whether levodopa and entacapone, if you start them early, can you help to prevent all these complications and side effects? Trials are ongoing, and before the results of the trials are out, we are not recommending that we should start all patients with levodopa and entacapone. So drug companies may tell you that you should start early, but at the moment, before the results of the clinical trials are out, I think our advice is still you treat with dopamine agonist, levodopa. If they have wearing off symptoms, then you add on the COMT inhibitors. Stalevo is not really a new drug. It's actually more like a combination drugs. It's the same as actually adding the Sinemet together with entacapone. So if a person is already taking Sinemet with COMT inhibitors, you may actually change them to Stalevo. So instead of taking 2 tablets, you just take 1 tablet. Similarly, if a person is actually taking Madopa and entacapone, you can also switch them to Stalevo because, as mentioned before, Madopa and Sinemet are interchangeable. So it's actually not really very new in the sense that it doesn't act on a different pathway. It's just a combination drugs. So briefly, we're going to run through the other non-motor symptoms of Parkinson's. So we have talked about all the different medications to treat motor symptoms. Now we're talking about non-motor symptoms. Dr. Christians has mentioned already very good slides on different types of constipations and how we manage them. So do remember, the only thing is that we always tell the patients to take more fibers, take more fruits, but water is also important. Nausea and vomiting, the only safe anti-emetic drugs that has minimal side effects on Parkinson's patients is actually domperidone or morphinium, because it is the only peripheral acting dopamine agonist available in Singapore. The rest of the drugs such as Maxilon, Stametil, all this thing, can actually cause Parkinsonism or worsen the complications of PD. So this is what you can read from the CPG guidelines already. Orthostatic hypotension, there are different measures, for example, drinking more water, having more pillows, stalking, so forth. But if you really want a pharmacotreatment, there are only probably 2 medications that's worth considering in PD patients, the fludrocortisone as well as midodrine. Midodrine is actually adrenergic mimetic agent. It causes vasoconstriction. It has very little CNS effects, so it actually acts on the peripheral system. So it's good to actually treat patients with PD, but it's actually very expensive, the drugs. The dose we give is about 2.5 milligrams, maybe once, twice a day, increased to about 5 milligrams 2 or 3 times a day. But be careful, if the patients have peripheral vascular diseases, especially the concomitant diabetes, then this may not be a suitable drug of choice. Fludrocortisone, on the other hand, increases the blood pressure by retaining sodium in water. And therefore, in heart failure patients, that's something to be considered. You really have to monitor that. And Dr. Christian also mentioned that you should actually check on the potassium. All right. So every time a person is already on fludrocortisone, they should be on potassium replacement. As a guideline, 1 tablet of the fludrocortisone should have at least maybe 1 tablet of the SPAN-K, 0.6 gram as a replacement. But check the UE, all right, before you actually start the patients of fludrocortisone, as well as monitor all the functions, like for example, are they having renal failure, heart failure, so forth. Erectile dysfunction, not much difference, although it can be it's not really a main early features of PD, but more like the later stages where there's some form of alternate dysfunction. The treatment is the same as a treatment of any other erectile dysfunctions in patients. Anxiety depression is actually quite common, occurring up to about 40 to 50% of patients. Treatment-wise, we can use any of the SSRI or tricyclic antidepressant, but one word of caution is we try not to combine SSRI or TCA with any of the MAOI inhibitors, because they may precipitate a serotonin side effects, which looks very much like the neuroleptic malignant syndrome. Psychosis and hallucinations. This may or may not be related to medication. And therefore, if a person with Parkinson's patients develop all these symptoms, first thing to come is actually, as what the slide says, review their history. Are there any other things that is causing all this psychosis and hallucination or not? So if there are certain drugs that is offending, we simplify the regime. So MAO inhibitors, anticholinergics, amantadine, maybe the first few drugs to go. Then after that, even dopamine agonists or the COMT inhibitors may have to be taken off, and eventually the patients may just have to rely on the lowest possible dose of levodopa. And that is usually for the sort of more advanced and later stages of Parkinson's patients. If neuroleptics is to be considered, our guidelines suggest only clozapine or Seroquel, because olanzapine and risperidone, although we know that it's actually a standard 2 drugs, higher doses can also cause all the anti-Parkinsonian side effects. And so far, the only 2 drugs that have minimal effects on worsening PD is actually these 2 drugs. Cognitive deficits, also about 20-40% may occur, and the treatment is as of any dementia. Of all the different cholinesterase inhibitors, donepezil and rivastigmine are the ones that have literature on treatment in PD patient that helps in terms of the behavioral symptoms, yet without worsening of the motoric effects. So I think that should be the last slides. I think we'll probably save the questions to later on. Okay, thank you.